for more on the situation inside Ontario's hospitals, I'm joined now by Dr. Michael Warner. He's the Medical Director of Critical Care at Michael Garron Hospital in Toronto. He joins us from that city. Hi, Dr. Warner. Good to see you. Thanks for your time today.
My pleasure. Thanks for having me.
Before I get into some of the stuff that Mike brought up, I just want to ask you, because my understanding is you've come off working 4 days in the ICU. What can you tell us and our viewers about what it's like right now on the front lines?
In our ICU, I can't get into patient specifics, but just about every patient we're caring for right now has COVID-19 and are obviously critically ill. Nearly all of them are on significant levels of life support. And the big difference now compared to the pre-COVID era is there are no visitors around, which is really very different. We're used to having families there to update in person, and now we can only speak to people on the phone, and that's very difficult for them and also for us as part of the care team.
Yeah, I was going to ask, that must be challenging to be able to communicate with. I can just picture being on both sides of the conversation. You know, I imagine it's not an easy one, even in person, but on the phone makes it even harder.
Well, in person, you can build trust because you can look in each other's eyes and work off body movements and positioning, et cetera. But on the phone, they've never seen you. Not only have they not seen us to trust us, but they can't see their family member in the bed on a ventilator. They have no idea really what that looks like, and you're trying to describe it to them. And it doesn't sound very good when you're explaining it. And then you have to ask for decisions to be made, which is even more difficult. So it's really an impossible situation for families.
What is the capacity issue like where you work? Because much of the conversation in the lead up to these weeks has been around whether or not hospitals will have the capacity to deal, particularly in the ICU, with incoming patients. What's it been like for you?
So there's some regionalization to COVID-19 in ICUs. I'd say in general, most ICUs in Ontario do have room. There are some ICUs that are using unconventional spaces to care for patients. But right now, there are an adequate number of beds to care for the critically ill in Ontario. I'm not sure about other provinces, but we do have the resources today to do what we need to do.
And what about the future? I know, and obviously nobody has a crystal ball, but do you have any concerns, I guess, going forward?
Well, there are projections that have been provided by the government, both a best case and a worst case, and what will really happen will probably lie in between. We also don't know whether there'll be multiple waves of COVID-19, so it's far too early to be reassured. I'm just taking it day by day and seeing what comes through the door and caring for those patients that need us. We need to still plan for the worst because it's best to be prepared, and that's what we're doing at our hospital.
The last time we spoke, you were concerned about the level of restrictions placed on people in Canada, that they weren't high enough, basically, that there weren't enough restrictions. That was a few weeks ago. What is your assessment now?
I think we spoke on March 17th, and incrementalism is what I was worried about, and incrementalism is what we have seen. I think we're getting close to where we needed to be 3 weeks ago. Hindsight's 20/20, but we on the front lines, I think, could understand what we needed to do. I think there's still inconsistencies across jurisdictions in terms of the number of people who can gather from province to province. I think Quebec it's 2 people, in BC it's 50. We need to be unified in our approach because this disease affects all areas, essentially equally at the end of the day. So we all need to have the same approach and the same strong messaging from government, policymakers, and public health that we need to stay away from each other, really without exception, unless you're doing your essential shopping or you're an essential worker.
The government has also talked a lot lately about personal protective equipment. They've been asked about it a lot lately as well. Do you have the personal protective equipment, the supplies that you need to do your job right now?
Today we have what we need. I think the challenge is that this is a marathon, not a sprint. So I need to know that we're going to have what we need 4 months from now because this could drag on that long. And we also need some clarity not only about production and procurement, but distribution and logistics. How will we get resupplied? How will we know that we're going to get what we need at a specific time? How are we sure that PPE conservation strategies are employed universally across Canada, because this is a resource that we're all going to need? There can't be inconsistencies. So those those questions I'm still waiting for answers to.
When you say conservation strategy, what does that mean?
So when you have a limited supply of personal protective equipment, there are safe ways to conserve the amount of PPE that you're using. For example, you could cohort patients who have COVID-19 in a specific area or unit and only change your PPE once per shift because all the patients are a danger to you in the same way. And if you stay in the same area, you don't need to change your PPE because you're not seeing patients without COVID-19. That's one strategy. There's also reprocessing options that I think are being explored that I think we'll have to look to.
And when you talk about distribution, how essentially does it work? I mean, you're one hospital in Toronto. Does Ontario, a big supply, let's say the government said today we've ordered 75 million N95 masks. Does Ontario get a portion of that based on what it asks? And then your hospital, is it based on need? Is it based on ask? How does it work?
I think that's a great question for the Minister of Health. I don't have a line of sight on that. I know that at my hospital, we know our inventory, and I believe the government has recently asked each hospital to collate their inventory and share it with the government so they can have some idea of where PPE is needed. But the details of that system, if there is a system being created, is something I don't know about, but I think there should be if it hasn't been created. We also have many hospitals who've been able to get PPE from the community, which theoretically could be shared among hospitals as well, assuming it's safe and effective.
And what about testing? Mike brought up testing as well, and whether or not the criteria needs to be expanded given the capacity that the labs have or that the province has isn't being fulfilled because there's not as many tests actually going to get processed. Do you think the criteria should be widened?
Well, I think in countries that have been most successful in containing COVID-19 have had the most extensive testing processes, like South Korea. So testing is the key. That's what the WHO says. How restricted that needs to be is not my area, but we do need testing. We need a turnaround time on testing that's immediate. That's also integrated with the PPE conservation strategy. If I have a patient who I think may have COVID-19 and they end up being negative, then I no longer need to wear PPE when I walk in that room. But until I get that test result, which could take 1 or 2 days, I still have to use the same precautions as if they had COVID-19. So the testing delays, lack of testing, and PPE conservation are all integrated issues.
And what do you think it requires of the government? Do they just need to do a faster job? What exactly is it?
So I'm not sure if there's a technology gap in terms of getting rapid point-of-care testing. There's also reagents and testing supplies that need to be procured. And then there's the labs and their capacity. As I heard from Mike earlier, the lab seems to have capacity in Ontario for 13,000 tests per day, yet we're doing 2,500. I think that there's something missing there in terms of why we're not reaching our capacity. And saying that our testing criteria needs to be narrowed doesn't make a lot of sense to me.
When you look at your experience in the ICU, as well as sort of more broadly speaking across the province, what do you think the priorities for the government need to be right now? Is it PPE?
PPE is the first link in the chain. Without PPE, no healthcare worker can enter the room to care for a patient who's sick or even dying. So that's fundamental. PPE is fundamental. We've heard a lot about ventilators, but ventilators don't take care of patients, people do. And we need to make sure that we have adequate investment in healthcare human resources, doctors, nurses, respiratory therapists. There may be 30,000 ventilators coming at some point, but there's only 953 ICU doctors in the whole country and 424 of them in Ontario. So someone has to take care of these patients, and it's not clear how that's going to happen. We also have to understand that ventilators are one piece of the puzzle, PPE is another, but we also need essential medications, intravenous pumps, monitors, physical beds, all these ancillary pieces of equipment that are just as fundamental to the care of a patient as a ventilator is.
What are the essential medications that you're talking about?
So what's difficult for the public to appreciate is that these patients are so critically ill that in most cases they require a general anesthetic so we can ventilate them. That means use the breathing machine in a way that isn't injurious to their lungs. These medications are given by intravenous infusion around the clock, and they paralyze the patient and sedate them, sometimes for 2, 3, 4, 5, even 7 days in a row. If we have many more patients requiring these drugs to sedate them, it's foreseeable that we could run out of these drugs, especially if multiple hospitals are hit at the same time. So without the medications, we simply can't treat the patients because we can't keep them safe on the breathing machine, assuming we have the breathing machine. So life support medications need to be procured. We need to look to private clinics, plastic surgery clinics, other alternative sources for these medications and make sure the hospitals get them.
Okay, I'll leave it there. Thanks for your insights this evening, Dr. Warner. Really appreciate it. And thanks for all the work that you're doing as well.
Thanks for having me. Take care.
Hi, I'm Vashi Capellos, host of Power in Politics. See more of our show by subscribing to the CBC News channel or click the link for another video.